As I mentioned, this is the Omicron edition to our current Déjà Vu. The date is January 14th, 2022. My name is Mark Bonta, not iPad 2. I'm a specialist in internal medicine at Toronto General Hospital, which currently for 100 funded general internal medicine beds has 166 inpatients, 62% of which are swab positive for COVID. So quite an intense situation. I have no conflicts of interest to declare. This is, again, a conflict-free, evidence-based talk simply for the form of education and supported by CAMH. Everything I give in the slides, I tried to make this as current as possible because the situation has significantly been evolving over the course of the past few days and weeks, and everything I provide is evidence-based for this talk today. I created the slides with the help of taking screenshots from various websites and mostly with the data help from the Ontario Science Table, which is a wonderful repository of information. So today we're going to go through the natural history of viral evolution and how it applies to the Omicron variant. We're going to describe the current epidemiology around this wave. We'll describe the impact of vaccination for COVID-19 and its associated variants, and we'll define the therapeutics that are effective against Omicron. On December 15th, right, just close your eyes and think back to November when there was a little bit of chatter about this possible variant. And, you know, we all thought, we got this, we got a vaccine, we'll be fine. It's almost Christmas, right? We've had a Christmas ruined. We've had a holiday season ruined because of COVID, not this one. And then on December 15th, you know, the headlines started creeping up and changes started to happen. This was mid-December when non-essential travel was advised against and the government started to accelerate booster shots. When you look at where Omicron came from, it was first reported to the World Health Organization in November, and it was officially reported at the end of November after being identified in Botswana and South Africa. This was then named a variant of concern 2 days later. Lots of variants have come up, but not all are labeled as variants of concern. The United States followed suit, as did we, labeling this a variant of concern November 30th. The first case was found in North America at the start of December. And here we go again, January 3rd, government announcement. You know, against my heart bleeds, but we're gonna have to shut your schools down again. We're afraid of reaching capacity. The science table has these wild predictions. You know, Kieran Moore, our chief public health officer of health, medical officer of health, you know, warning against the dire situation in the hospital. We've all heard this before. We've seen it before, school closures, but it was never this bad. This is a headline from yesterday, right? Whereby we're closely monitoring our patients in hospital and closely monitoring our patients in the critical care environments with COVID-19, with Omicron being the dominant strain. What's different this time around is the healthcare system is burnt out. People are exhausted. We've depleted a lot of resource. And the patients who are admitted to hospital, we obviously watch those ICU numbers, but it's the non-ICU patients that are consuming a ton of resource. And so this is my world, general internal medicine, with a huge volume of hospitalized patients who are COVID positive. Well, how do you get COVID positivity? Well, there's the famous COVID virus with the spike protein. And the spike protein are those little notches on top of the virus. And those notches bind to this receptor on cells, which is the ACE2 receptor. And I put that picture there because our treatments are directed at neutralizing that virus, either by vaccines, whereby antibodies can consume the virus so that it can't enter cells and replicate and make you sick. And we're coming up with novel therapeutics to target that specific receptor that it binds to. When you look at the treatments for patients who are sick with COVID, despite being vaccinated, some of the treatments alter how the cell comes in, how the virus comes into your cells and makes you sick. And some of the treatments are directed at targeting and neutralizing that spike protein. As I described when I walked through that nice picture there, here's a formal scientific picture of the virus binding to the ACE2 receptor getting into cells and replicating and making more and more of its cells to create an inflammatory response that makes you sick. When we look at the mutations, this is a wonderful 3D analysis of the spike protein, right, which is that notch on top of the virus that binds to our cells and makes us sick. The Omicron variant has many mutations to that spike protein, whereas the Delta variant that we previously dealt with in the last wave has fewer mutations to the spike protein. What that means is this is the natural history of viruses. They evolve, they come up with ways to survive, they come up with changes based on the people that they are exposed to. If those people are fully vaccinated, partially vaccinated, have other cellular makeup, and mutations happen. Some mutations lead to burnout. The virus becomes less lethal. Some mutations don't really do anything to how it works. Some mutations make it ineffective. And as I've mentioned, there have been lots of mutations and lots of variants, but not all have been named variants of concern. And but some, based on these mutations, change how the virus works. And as we've learned with Omicron, it's far more infectious. It doubles much quicker. It makes people sicker faster, albeit the jury is still out if they actually get sicker than they did with Delta. What we do know is the replication phase is far faster. And so people go from picking it up to getting symptomatic in a much shorter way. And because of these mutations to the spike protein, some of the treatments that we have available, including monoclonal antibodies that we created for the Delta variant, do not work. Again, the symptoms of COVID, and everyone jokes about now with Omicron, how are the symptoms different? Well, COVID gives all the same things: breathing problems, fevers, chills, aches or pains, loss of taste or smells, vomiting and diarrhea. What we're seeing in the Omicron variant is a higher percentage of GI type symptoms, a higher percentage of the non-specific symptoms, fevers, chills, aches, and a higher percentage of unusual symptoms like back pain. Regardless, any of those symptoms can be associated with COVID-19 and the Omicron variant. And as we've learned, assume that any symptom you have is COVID and assume it's COVID until proven otherwise. Pretty crazy advice. Now let's look at the data and let's look and see what's happening. On the top, we have the COVID-19 cases with the blue bars reflecting the vaccinated population, so at least 2 doses, and orange representing the unvaccinated population. And as we move from left to right, we see that the COVID cases, in terms of the cases per million inhabitants, are higher in the unvaccinated. But a lot of vaccinated patients are testing positive. Whether or not this means that they're symptomatic or not, I'm not commenting in this graph. But what we do see is both vaccinated and unvaccinated are testing positive for COVID, but the unvaccinated test at a far higher rate compared to the general population. But when you look at the patients that are in hospital, we see that being unvaccinated carries almost a 5-fold risk of landing yourself in hospital if you get COVID. And if you compare ICU admissions, if you're unvaccinated and you get COVID, you're 20 times more likely to land in an ICU. And this is very important because when you look at the actual cases and you look at the number of cases amongst unvaccinated people in the bottom left there, and the cases among people vaccinated with 2 doses, it kind of looks like the cases are just as common if you're unvaccinated or not. So why get the vaccine? Well, the answer is up there at the top. You're way more likely to get sick to the point of coming into hospital and way, way more likely to end up in an ICU. This also shows some of the occupancy rates comparing the 2 populations there in the hospital and ICUs. And you see this stark, steep curve, which is essentially where we're at as of Tuesday when this data was last released. When you're looking at our vaccination effort, we're doing pretty well for people aged 50 and over, and we're increasing the number of doses and boosters in those populations. But when you start to get down to the younger age, specifically those in the pediatric age range, we see less than half of pediatric age populations being vaccinated. But overall, we're not doing bad. When you look at the uptake and take in vaccination, we see that after the summer waning of doses administered, we've seen a huge uptake there. And you can see the blue bar are people who have had 1 dose. purple are the people who have had 2, and the yellow is the booster dose. And the booster doses have significantly increased in the past 4 weeks. And this is because we've learned that the booster doses can confer significant protection against illness from the Omicron variant, a far different outcome than those who are doubly vaccinated. And this is why we're really pushing the boosters on our general population. I put some general data here to share, looking at some of the activities that we do that helps to frame some of the thoughts that we're all having about the restrictions that the government places, about some of the questions that our patients and our clients and our family members may be asking us about what can they do and what should they not do. I'm sure a lot of you are fielding many questions. I'm getting a ton of texts, WhatsApps, and calls about people asking what to do with their kids, send them back to school, get them vaccinated. So looking at information, and again on the science table, gives you good data to answer those questions. As healthcare providers, I'm sure that you're all leaned on by many of your neighbors, friends, and families for advice. So share them good, objective data. When you look at some of the low-risk activities associated with the COVID virus and transmission, staying at home, going to parks, and walking around generally have low risks of infection associated with them. Some of the higher risk activities include the workplace, specifically those in large congregate settings, retail and recreation, right? Going to the casinos, perhaps going to the bars, going to shopping malls, again, large congregate settings where not everyone is vaccinated, not everyone is masked, and transit itself, especially as we get to the winter months and it's difficult to open the windows and ensure good filtration and ventilation. As people were coming back to the workforce in the falls and filling up our subways and buses, there's a slight uptick in the transmissibility in terms of high risk behavior. I share again the data there. And this is updated on the science table, and I put it there for everybody to have a look at so that you can see the number of cases that we have in the hospital, the number of hospitalizations, positivity, ICU occupancy, comparisons with vaccination rates, and how this is changing day over day. Because everyone is thinking now, well, we're in the middle of this wave, we're in the middle of this surge. When is it going to plateau? When is it going to end? When are we going to get quote unquote back to normal? And I'm sure like all of you, you've accepted that there is going to be no return to a back to normal, but we're going to have to learn to live with viruses. And we're significantly going to have to change how we behave when we get sick ourselves. I put this slide up as a garbage in and garbage out because we're certainly experiencing that right now with respect to case counts. And we ran out of the capacity to test everybody with PCR. We have people doing rapid antigen testing at home. We don't know how many of those people are testing positive, if they did it properly and had a false negative, and if they're reporting that data. So the number of cases are absolutely meaningless right now. Unless we're testing everybody in the country on a daily basis with PCR testing, we have no idea of how prevalent Omicron and COVID positivity is. And we've run out of the capacity to test people. Moreover, when people say, well, let's open more testing centers and let's do more tests, let's ship them out. Well, some things are out of our control, like supply chain issues, which have significantly hampered Alberta's efforts to get more PCR tests. But we're taking lab technicians, we're taking healthcare professionals to swab people, to analyze these tests and give results. And this is providing a considerable amount of strain on the healthcare system because we need healthcare professionals, all of them, including lab technologists, administrative staff, to be helping us in the hospitals as we deal with this surge in admitted patients. So that's why looking at numbers like hospitalizations is quite helpful. And that's why looking at numbers of patients with COVID who have COVID syndrome, who are having symptoms from COVID, versus patients who are admitted to hospital with incidental COVID swabs. And I can say this from direct experience working across many institutions. We have patients who are coming into hospital with COVID syndrome, shortness of breath, requiring oxygen, having fevers, having chills, having sweats. And then we have patients who come in for other issues, heart attacks, GI bleeds, falls, some delirium, who swab positive. And while we do know that there's a higher incidence of some of those issues, namely myocardial events and thromboembolic disease in COVID, we don't know how many of those are incidental, and the reason that the patient is in hospital is unrelated to COVID. Moreover, we never swabbed everyone in hospital for influenza during every flu season, so we don't really know the impact that influenza had on all of those non-influenza-like presentations to hospital. So that's why case counts are completely meaningless. That's garbage in, garbage out. We need to look at the number of patients who are coming into hospital, consuming resource with COVID syndrome, the number of patients consuming ICU resources, looking at other things like wastewater data to get a better idea of how we're doing with this current wave and when we can start breathing a collective sigh of relief to know that we've come over the crest and we're dropping down. Again, this is a headline there that which didn't zoom out, but it basically tells us that the numbers are useless. So what advice do you give your patients? Do you give your friends now that we got this Omicron wave here? You know, you have some people, and I would say Joe Rogan is one, you know, well, I'm young and healthy, so let me get this Omicron. It's mild. It's just a cold, and I'll just fight it out and I'll feel better. Well, I still don't wish Omicron on anybody, and I would not like to get it myself. And this is because we don't know about the long-term impacts. We don't know if Omicron is truly mild. Sure, it tends to show a predominant upper respiratory tract infection. We're having fewer people in the ICU. Definitely vaccinations are incredibly protective against illness, but we have a totally different population now. We have a population with a above 85% vaccination rate, right? So we can't compare the illness today to the prior waves when people were unvaccinated or singly vaccinated. It's simply not a fair comparison. And what we're learning about long COVID syndrome and the long hauler syndrome is it's something that's going to be real. It's something that's going to lead our population with a significant amount of disability. So you don't want COVID. Get your third dose as soon as possible. You can significantly increase your body's capacity to have an asymptomatic or non-breakthrough infection with COVID, and you can significantly decrease your chances of landing in hospital. Reconsider your indoor gatherings. We've learned so much about the virus and viruses in general, so apply what we've learned. Make your events outside. Wear a mask when you're visiting. A lot of debate around the N95 masks or the KN95 masks, whether or not this is airborne, how transmissible it is. If you're comfortable wearing an N95 mask and can do that, and that helps you feel safe, you know, you can keep it on your nose all day. You're going to be at an indoor gathering. Perhaps you're immunocompromised, or you just say, until the jury is clear, I'm wearing an N95 mask, go right ahead. For me personally, I'm wearing my surgical mask unless I'm seeing patients with suspected or confirmed COVID, at which point I'll put on my N95 mask. But when I go into the store to get an item, to the grocery store, etc., I'm wearing a surgical mask. Make sure your air is filtered. Open up the windows a crack. I know this weekend might not be a good weekend to open up the windows a crack, but doing that when the temperature is a little bit more livable can certainly help to ensure that you have good ventilation and fresh air, which significantly diminishes the opportunity for airborne viruses to move around. The news came out this morning that Ontario is making the vaccine eligible to immune-compromised individuals. Now, why are they doing this? Well, the data is coming out, and we're recognizing that of the vaccinated people who are landing in hospital and consuming inpatient beds, both on wards and ICUs, predominantly those who are immunocompromised are at risk. And the reason for that is if you're immune suppressed because you had a liver or lung transplant and are on anti-rejection agents, if you're on chronic biologic or immunosuppressive treatments for a chronic autoimmune disease, your body's ability to create memory cells and T cells when you get the vaccine is impaired. And so these are the people who have a weakened immune system, who have less efficacious responses to the vaccine, but another booster and a fourth dose can significantly improve that. And so we're making this eligible to those who are immune compromised. When you look at how you manage these patients, again, the science table is updating things. And this is the update as of, I believe, January 8th, which is the most recent update. And it has clear instructions for what to do. And I'm not going to go through these specific treatments and recommendations. The long and the short of it is if you're needing oxygen from COVID, we know that steroids can help. We have an interleukin antagonist called tocilizumab, which blocks interleukin 6, which can decrease inflammation and can decrease your chances of needing a ventilator and increase your chances of surviving. Our province is running out of that, as we are running out of everything else. And baricitinib is another interleukin 6 antagonist, which hasn't been studied against COVID, but is believed to be a good replacement for tocilizumab. But the reason for me sharing this is not for you to memorize drugs and biologics that we treat critically sick COVID people with, but it's to say that we have a great group of scientists, epidemiologists, virologists, and infectious disease experts who are actively updating the recommendations and helping all of us as clinicians in hospital decide what to do. We also have what treatments don't work. And if you look in the bottom right there, ivermectin's screaming at you because no, it doesn't do anything. But unfortunately, the monoclonal antibodies that we had, Carcivimab, which we were giving for the Delta variant, are ineffective for Omicron because Omicron has too many mutations, just like in that slide I showed you earlier. And the monoclonal antibodies we previously used do not work. However, there is a new monoclonal antibody called sotrovimab, which is directed towards Omicron. This was published in the New England Journal of Medicine, and it was studied at many sites, including at McMaster. And it was found to significantly reduce both hospitalizations for people with mild Omicron symptoms and ICU admissions and death. The challenge is we're rationing this agent. We have very few sotrovimab monoclonal antibody IV preparations. It's required to be given intravenously with nurse administration supervising. And what we've learned is it's best for specific patient populations, generally those who are immunocompromised and generally those who carry other risk factors, such as severe kidney disease, uncontrolled diabetes, or obesity. We have a nice algorithm here to help decide which people would receive this monoclonal antibody. But again, based on my knowledge of administrating this medication across a few hospitals, it's likely that we're going to run out of this in the next few weeks because we have so many people getting Omicron. But again, the province is working hard to ration this and make sure that only those who specifically meet indications will receive it. And that's why these guidelines are constantly updated and provide clinicians with a toolkit to decide on their use. Another medication, and this will make all of the psychiatrists on this echo happy, that can help with reducing the development of severe COVID is fluvoxamine, which is an SSRI medication and has been shown if you give it to people within 7 days of symptoms, you can reduce their need for hospitalization, for oxygen, and improve mortality outcomes. I have a typo there. It says pre-immunization daily. It was actually pre-immunization data. So this was found to be efficacious in the pre-immunization days. That's when it was studied, but it's now a formal recommendation as per that dosing criteria I've outlined there for people who have mild COVID that you're seeing in the outpatient environment in the COVID testing center, so not for inpatients. Another medication is budesonide, which is an inhaled corticosteroid, which can reduce the need for oxygen and reduce the need for hospitalization. Children, we need to start vaccinating our children. Bookings are open. The vaccine is incredibly safe in kids. And this is a target population who is unvaccinated or was unvaccinated until recently. And we're now offering the vaccination to children. A lot of questions come up for people. Direct them to Max the Vax. This website put out by the Ontario Association of Children's Aid Societies is fantastic. It has information that's good for children and directed for children and information for adults. There's good videos, there's good handouts, there's good PDFs, and there's a constantly updated Twitter feed whereby you can have your questions answered as a parent or as a child about the safety and efficacy of vaccines. In the pediatric population, now we've given over 3 billion doses worldwide, and we've studied this extensively in children. It's incredibly safe, very mild side effects, maybe some pain at the injection site, some general malaise. The only contraindication is an allergy to the vaccine or vaccine components. So food allergies, other allergies are not contraindications. It can be timed with other vaccinations like the flu and other booster shots. We space apart the two doses a little bit further, given the children's immune systems. But right now, we only have 45% of those age 5 to 11 being vaccinated. The rates were increasing significantly and then plateaued recently. So we really need to compel parents to vaccinate their children to protect them. Is COVID killing children? Not really. Definitely less lethal than things like RSV, which have been ripping around for many years and have been hurting children, but definitely something that we don't want our children to get. And to preserve the frail nature of these schools openings and closing, which I feel is purely political, we need to make sure that we're keeping our children safe and doing everything we can to help them remain in school for in-person learning, to protect their mental health, to help them develop, and to help them socialize and become functioning members of society down the line. As you've seen, this has really put a burden on our system. We've called code oranges for staffing crises. We have significant burnout in nursing staff, medical staff, RT staff, significant attrition and turnover, a lot of changes to people, minimizing vacation usage, having people work extra long shifts. This has really damaged our system. So taking all of this together, this is coping with COVID. So go back to everything that myself, that my colleagues from the mental health environment have been recommending. And this is common COVID 101 that we've been preaching since the start. Put a limit on how much time you watch or read the news. It's depressing. Make time for some humor. Watch something brainless on Netflix. Focus on the positive. Although negative things are happening in our clinical environment and on the news, we still have good things happening and good things to be grateful for. Our hippocampus tends to encode negative emotions stronger than positive emotions, so help it encode those positive emotions and reflect on them. Focus on good sleep hygiene, no screen time before bed, no caffeine before bed, limit the news before bed, do something relaxing and distracting before bed, make time for exercise. Stay connected with people using new tools. There's been some bad things about staying at home. We've learned about the weight gain, the isolation, the substance use, but there's been some good things. For one, my parents are seeing my kids almost daily using WhatsApp video and Zoom. They never used to use that stuff before. Being connected definitely helps, and it helps all of us. Monitor yourself and others for mental health sequelae. As we know, the impacts of isolation, the impacts of the pandemic and working in this state is quite severe. So make sure that you're keeping an eye on yourself, loved ones, and your patients for the impacts, and provide this general recommendation and advice to them. There is a light at the end of the tunnel. We're going to learn from all of this. I think we're going to have to learn how to live with viruses again. This is not going to go away. I put the light at the end of the tunnel here because based on the situation on the ground today, at Toronto General Hospital, our inpatient admission rate was lower today than it was yesterday. The overall COVID percentage population is lower. The length of stay of those patients is less, so they're not staying as long. They're turning over quicker. My feeling is that we're reaching the plateau of inpatient admissions. And at the end of this, we're going to learn a significant amount. At the end of this, we're going to have a population that is significantly vaccinated. We're going to have a population that has been exposed to this virus and developed immunity. And so perhaps that dream of herd immunity, perhaps that dream of this becoming endemic will be realized. And hopefully we'll take a lot to heart to learn from this awful pandemic about how we can manage viruses in the future. And this has also unmasked a lot of abnormal parts of our healthcare system, and hopefully will help us to identify things that we can change and improve down the line. All of my information is from the science table. Go look at it. If you're a data nerd, it's fantastic, quite helpful, very objective information for healthcare providers and for lay public. So thank you very much for your attention. I'm going to stop sharing my screen